In our session with Medical Sciences, today we are privileged to take you through asthma and chronic obstructive pulmonary disease. These are respiratory diseases, so we're going to see the differences between asthma and chronic obstructive pulmonary disease. We shall look at the symptoms, the causes, the pathogenesis, and the diagnosis of these particular diseases. And as we begin, we urge you to subscribe if it is your first time to be on this channel. Then like the video and share to many others. So in asthma, you're going to have asthma, and this asthma is reversible condition. It is a reversible condition characterized by bronchial obstruction. It is characterized by bronchial obstruction together with bronchial hyperresponsiveness. There is hyperactivity or hyperresponsiveness of the bronchial, which is part of the lung. So this bronchial obstruction is brought about by the narrowing of the airway or of the bronchus. And this narrowing of the bronchus and the hyperresponsiveness, which we have said is reversible, it is episodes. It is triggered. The trigger factors include the causes of asthma include, we are going to see allergens. These are environmental allergens such as pollens, such as smoke in the environment. Then it can be molds or anything you inhale from the environment. Then another one can be due to exercise, increased exercise. We can see cold air, breathing in cold air during coldness. We can see aspirin-induced asthma when someone is on treatment of aspirin. And many other causes can result into this. So exercise, allergens in the environment, all of them, and certain upper respiratory tract infections such as viruses can trigger episodes of asthma, which can trigger these narrowing. And what are the signs? How do you know that someone is having asthma? The signs and symptoms of asthma include chest tightness. There is chest tightness. We are going to see wheezing, and these signs are both in the asthma and COPD. There is wheezing, there is dyspnea. Dyspnea is shortness of breath. Shortness of breath is also among the signs. So these are the major three signs, not forgetting cough. And the cough in asthma is always dry. It is always a dry cough. So these are the signs and symptoms in asthmatic patients. That is chest tightness, wheezing, dyspnea, that is shortness of breath, and cough, which is always dry. After looking at these signs, then we want to see the pathogenesis. In the presence of these triggers, how does it come about? So we are going to see presence of these triggers, which we are talking about. They are going to induce within the airway. If we have the airways with the bronchus, which divide into the primary and the secondary bronchioles, which further divides into the tertiary, and then the bronchial system, which goes to the air ducts and then the air sacs. So we're going to see that within the bronchioles, presence of allergens, or which we can call antigens. These allergens which are foreign, or which we can call antigens, they are going to activate the dendritic cells. And these dendritic cells, they go and attach to the naive T lymphocytes. And these naive T lymphocytes, they become activated to T helper cell type 2. And these T helper cell type 2, they are the ones that have ability in production of chemokines like the interleukins. For example, the interleukin 5, which is responsible, which goes to the B cells, that is the B lymphocyte, and command it to proliferate to produce antibodies, especially IgE type, that is immunoglobulin epsilon. So the interleukin 5 produced by the T helper 2, they are the one that trigger production of IgE from the B cells. Whereas interleukins such as interleukin 3 and interleukin 13, they are going to recruit their mast cells. We are going to see mast cells. These are mast cells, and sometimes basophil in blood, and whereby after production of these IgE antibodies, they come and sensitize the mast cells. They come and attach on the mast cells using their Fc portion. And in the case of another episode of the allergen or the antigen in the environment, it is going to come and trigger the sensitized mast cells. This is the antigen. It triggers the sensitized mast cell to undergo degranulation. And how does it undergo degranulation? This one, after heat binding, it undergoes degranulation, leading to production of inflammatory mediators. And among the inflammatory mediators produced by degranulation of the mast cells in response to the allergen from the environment include inflammatory mediators such as, we're going to see production of leukotrienes, for example, leukotriene C4, D4, and B4. Then we shall see production of histamines, and then prostaglandins, especially prostaglandin D2. This prostaglandin D2 is produced in presence of an enzyme known as lipooxygenase, whereas leukotrienes, prostaglandins is in the presence of COX, that is cyclooxygenase enzyme, whereas leukotrienes is in the presence of lipooxygenase enzyme, which produce these chemotactic and inflammatory mediators. And all these inflammatory mediators we are seeing being produced. After being produced, these inflammatory mediators are the ones that cause they bring about bronchospasms, and together with airway obstruction, which can result into airway obstruction. Then also they induce inflammation. Then they can also result into hyper responsiveness. So these are the end results after production of these inflammatory mediators, that is leukotrienes, histamines, prostaglandins, and platelet activating factors, especially type 4, which bring about these inflammatory responses, that is bronchospasms, inflammation, and hyperresponsiveness. These are inflammatory mediators. So this is the pathogenesis of asthma. So we're going to see that in asthmatic patients, these bronchospasms within the bronchioles and alveolar sac, they are going to cause narrowing. They lead to narrowing of these bronchospasms, bring about that if there is the smooth muscles surrounding the bronchioles, they are going to begin narrowing due to the contractions which leads to the narrowing. Therefore, during inhalation, it is easy to inhale oxygen at the beginning, but it is hard to exhale carbon dioxide. So we are going to see accumulation of carbon dioxide within the alveolar sac and increased partial pressures of carbon dioxide in the alveolar sac. This is which is coming from the blood vessels. From the blood vessels and tissues, it enters the alveoli to be exhaled, but because of the narrowing or the obstruction of the airway, it is difficult to exhale this carbon dioxide into the air or environment. So this accumulation of carbon dioxide, it is going to cause inflation, hyperinflation of the lung. So if here there is a lung, the diaphragm is going to flatten and increases in size. So it results into hyperinflation. Hyperinflation results due to accumulation of carbon dioxide. We are breathing in oxygen, but it is difficult to breathe out carbon dioxide. And as it progresses, even the oxygen tension reduces. There is reduced oxygen tension, meaning little oxygen is being exchanged to reach into the tissue. So there is little oxygen, decreasing the partial pressures of oxygen. And this one results into what a term known as hypoxemia. Hypoxemia. Then increased the partial pressures of carbon dioxide results into what we call hypercapnia. This is due to increased partial pressures of carbon dioxide. Then hypoxemia is reduced levels of oxygen. So all these complications, the hyperinflation of the lung can continue and bring about what we call pneumothorax. And what is pneumothorax? That the pleural cavity surrounding the lungs are surrounded by what we call the pleural cavity, having the visceral and the parietal layer. So when there is hyperexpansibility or inflated lungs, it can easily burst, creating an airway which will allow air to escape from the lung into the pleural cavity. And this one results into what we call pneumothorax. So pneumothorax is due to the escape of air from the lungs into the pleural cavity. And that is what we term as pneumothorax. And it is very dangerous. It can lead to respiratory failure due to decreased negative pressure within the lungs. So this is the pathogenesis we can discuss with you under asthma, which we have said it is reversible. You can reverse the episodes of asthma attacks, which we have seen. You can know them by looking at wheezing, dyspnea, cough, which is always dry. And majorly, the onset occurs at night, but many times it can be even at any time of the day. But the most result is obstruction of the airway and hyperresponsiveness, which results into increased the partial pressures of carbon dioxide due to difficulty in exhalation. And when it increases, it causes hyperinflation, which can result into pneumothorax, and then increase the partial pressures results into hypercapnia. Then even when oxygen tension is reduced, it results into hypoxemia. And these two conditions can result into secondary respiratory failure. So these ones can result into secondary respiratory failure. So that is the pathogenesis of asthma, which started by triggering the mast cells to produce inflammatory mediators. Then after looking at asthma, before we look at the diagnosis, we are going to continue and look at how does it differ from COPD. So the next thing we can talk about is COPD, chronic obstructive pulmonary disease. This is, for it is irreversible. This is irreversible. It is different from asthma because this one can be reversed, but this one is a progressive chronic destruction of the bronchial walls and alveolar walls. In asthma, the onset is majorly in childhood and adolescent. That is the onset, whereas in the COPD is seen commonly in adult life or in later life. We have seen in asthma, the major trigger factor are the allergens, the exercise, aspirin-induced or cold air or other infections, whereas in the COPD, the major cause or the major trigger is smoke, cigarette smoking. Cigarette smoking, which brings about irritation or any other environmental pollution irritants. Environmental pollution, which brings about respiratory irritation. Bring about respiratory irritation. So the major one, which is 80 to 95%, is smoke, either cigarettes, majorly cigarette smoker. So it is seen in smokers and those ones which have quitted smoking, causing irreversible airway limitation. This one results into irreversible airway limitation. It results into airway limitation, or you can call it obstruction. And this limitation or obstruction of the airway is brought about by, one of them is fibrosis. We are going to see fibrosis of the epithelial lining, then hypersecretion of mucus hypersecretion in the linings of the bronchioles, then inflammation of the bronchioles and the alveoli, and then loss of elasticity. Which can result into failure of the lung or tubes to recoil. So there is loss of recoiling of the lung, which results into collapse. So these airways collapse due to loss of elasticity. And we are going to see how do these things come about to cause obstruction or limitation of the airway. We are going to see, in the presence of this smoke, cigarette, especially cigarette smoke, and other conditions that can be genetic. There are other genetic causes like deficiency of alpha-1 antitrypsin. It can also lead to that. And this one can also progress into even influenza and pneumococcus. They can also bring about that, especially viral infection like influenza. Then genetic conditions like deficiency of alpha-1 antitrypsin can also trigger. So what happens that the alveolar macrophages, we're going to see that the alveolar macrophages, due to presence of irritation or irritants like smoke or like polluted air, when you breathe them in, they are going to come and trigger the epithelial lining of the bronchioles by recruiting more fibroblasts. And these fibroblasts result into what we call lung fibrosis. That is one way which can result. Due to production, then another situation that these alveolar macrophages, they produce what we call chemotactic factors, like tumor necrotic factor alpha, then interleukins. And these interleukins, once produced, for example, and leukotriene B4, these ones, they are going to attract neutrophils. So these ones attract what we call neutrophils. They attract neutrophils and sometimes monocytes. And when attracted, these neutrophils, which come into play, they are going to be triggered to produce reactive oxygen species like peroxides and hydrogen peroxide. Then another thing, they are going to decrease levels of alpha-1 antitrypsin. So the levels of alpha-1 antitrypsin decreases, and at the same time they are going to produce proteases. Proteases like elastase are produced by these neutrophils. And these proteases like elastase, they are going to go into the alveoli. Like if we have the alveoli here, and another one we have another one here. So what happens in the COPD, these ones can cause either chronic bronchitis or emphysema. Chronic bronchitis, these ones are resulting in two situations. One, we are calling it emphysema. Another one is chronic bronchitis. When these proteases go and digest the airways, those are the bronchioles, and they start digesting the elastin tissue. These bronchioles, they are going to lose elasticity and can undergo collapse, or they lose their recoiling activity, which can lead to collapse of these tubes. Another thing, the production of reactive oxygen species, they are going to trigger inflammation of these bronchioles. Then another situation which comes in is that they are also going to increase mucus secretion, and this mucus accumulates. It is going to accumulate into these airways, and after accumulating, then it cannot allow carbon dioxide to be inhaled, to be exhaled. So there is obstruction. That is what we are calling chronic bronchitis. That is destruction of the bronchioles, or the air conducting passages. Whereas emphysema, for it, we are going to see destruction of the alveolar walls. Destruction of the alveolar walls. So if we have these alveolar walls, they are going to be destroyed by these proteases. So the proteases begin to destroy the alveolar walls. They destroy them, losing their elastic, and they later lose their expansibility, and sometimes they can be eaten, that they become one. So you see the air sacs increasing in size under chest X-ray. And this is what we call emphysema. Emphysema is due to destruction of the alveolar walls. Destruction of alveolar walls, which are seen under X-ray as alveolar blebs. Alveolar blebs are seen from there. So that is emphysema we are talking about. But chronic bronchitis is just chronic inflammation of the air passage, that is the bronchioles, due to accumulation of mucus, due to trigger of inflammation by the reactive oxygen species like hydrogen peroxide and superoxides, which bring about destruction. So we are saying that COPD has two conditions, that is emphysema and chronic bronchitis. Bronchitis, if the inflammation is within the bronchioles, then emphysema, if there is destruction of the alveolar walls. So when they are destroyed, still they can result into this hypoxemia and hypercapnia, which can result into secondary respiratory failure. And always, as a doctor, we have to be cautious when we are using oxygen as the treatment. Oxygen is always prescribed when there is acute episodes. But with chronic obstructive pulmonary disease, avoid using oxygen as treatment because it can result into respiratory arrest. Because here in this condition of chronic obstructive pulmonary disease, the respiration is being controlled by low levels of oxygen, because high partial pressures of carbon dioxide has become tolerant. So when you give more oxygen, you remove the trigger factor of breathing, which can result into respiratory failure. I think that is a very big thing to note. So this is what we can discuss under asthma and COPD. We have seen in asthma, the triggers are allergens and is characterized by hyperresponsiveness, whereas here, and it is reversible. Here it is irreversible, and it is due to emphysema, that is destruction of the alveolar walls, or inflammation of the bronchitis triggered by majorly smoking. Whereas this one is majorly allergens, exercise, cold air, or aspirin. That is what we can talk about. So, another thing which we forgot to discuss here is that there is another interleukin known as interleukin 4, which is going to recruit the eosinophils. And once eosinophils are recruited, they are the one that also participate in inflammation during asthmatic attacks. So there is always, so the cells involved in asthma, we have lymphocytes and eosinophils. Whereas in COPD, we have neutrophils and monocytes, or what you can, in tissues, we call them macrophages. So that is also another difference. Apart from being reversible, another one being irreversible. And we have seen also difference in trigger factor, and also another difference in signs. The signs are the same, but this is dry cough, whereas in COPD, it is always productive cough. There is always mucus production, especially in the morning times. So there is always productive cough. In COPD, there is productive cough with mucus, due to mucus accumulation triggered by the inflammation and oxygen reactive species. You can ask yourself that what happens in normal situations when there is no smoke, or we see that the proteases are always balanced with the alpha antitrypsin. But in this condition, due to production of these reactive oxygen species, there is a depletion of alpha-1 antitrypsin, which is always in blood and monocytes. So when it is deficient, then the proteases have ability to go and start destroying the elastin fibers of these bronchioles and alveolar spaces, which results into emphysema or chronic bronchitis. So after this, we are going to look at the diagnosis of these conditions. So lastly, we are going to see the diagnosis. How can we diagnose asthma together with COPD? As a medical doctor, we need to differentiate them. Though clinically or by signs and symptoms, it is not easy to differentiate the two. So under diagnosis, the tests which are performed, one, we begin with history of the patient. Then we look at the physical examination, that is the physical exam. Then we go to the tests which we can perform. And under tests we can do is, the gold standard is spirometry. We can do chest x-ray. We can also perform methacholine challenge test. Methacholine challenge test, which we call bronchoprovocation test. And even we can also perform a CBC on blood. Can also perform a CBC. And under spirometry, here we are interested in two factors. That is forced expiratory volume in 1 second, and we also look at forced vital capacity. We know that on spirometry, if this is a spirometry, the graph, and this is the vital capacity, the lung, the capacity of the lung is 6, from here to here is always 6 liters under forced expiration. So if I inhale 6 liters under forced expiration, I can only remove 5 and I remain with 1 liter. So sometimes the first vital capacity is always 5 and the first expiratory volume can be like 4, but they differ. So we're going to see that in spirometry with asthmatic patients, we shall do what we call first expiratory volume in 1 second divided by first vital capacity ratio. And when the ratio is less than 0.7 or 0.8, that one indicates asthma or sometimes COPD. Then on history, there must be history of either smoking or history of triggers, like when you're exposed to allergens, to coldness, or to exercise, those who cannot tolerate exercise. On physical exam, there is always chest silence. There is silent chest under asthma. There is a silent chest. And then remember, there is always dry cough in asthma. But with the COPD, there is productive cough. Productive cough. And when someone comes telling you that they have been experiencing productive cough, especially in the morning times, for more than 2 months or 3 months, and maybe they have a history of smoking, and they are hereditary, you can always suspect COPD. Then when you suspect COPD, that's when we can do spirometry. Spirometry can be fast done, and after doing it, we also go and do what we give a bronchodilator. Bronchodilators, we have like beta 2. Beta 2, we can either give beta 2 agonist or M3 antagonist, but majorly beta 2 agonists. When they are inhaled, after inhaling them, we repeat spirometry and we look at the first expiratory volume. So when you have given a bronchodilator and maybe you assessed the volume, at first you noted maybe this one was 4 liters. Then after giving a bronchodilator, maybe at first it was 2 liters. Then after giving a bronchodilator, it shoots to 4 liters. This one can be used as a diagnostic marker of asthma. So this one indicates that maybe someone has asthma. But some percentages, they don't respond. So sometimes you are forced to go and do a confirmatory of methacholine challenge test, which we call provocation. So if you do spirometry, if you do bronchodilator, you give a bronchodilator aerosol or spray or inhalers, then you had noted the first figure before, then after you do it, you find there is a response to these bronchodilators, because we said asthma is hyperresponsiveness. And you see it is positive, that one confirms asthma. And when it is negative, after giving a bronchodilator, then you continue and do methacholine challenge test. And if methacholine challenge test is done and there is response, then we are able to when there is a response, we are able to confirm that the patient is positive. This methacholine is a muscarinic 3 receptor agonist, which increases bronchodilatation. For it causes bronchoconstriction. This one causes constriction. So if I give it and the condition worsens, if a patient had 3 liters of first expiratory volume in 1 second, and after giving methacholine, it worsens to 2 liters, or it decreases, that can confirm that the problem is with asthma because of the response to the methacholine. Whereas bronchodilators, they use them to see if the situation can revive. That is what we can use for. Then with the chest x-ray, which I can put it here, if I do chest x-ray and I see hyperinflation, sometimes there is always, with asthma, we can see hyperinflated lung or normal lung. That one can, based on the clinical exam and the methacholine challenge test together with spirometry. But with COPD, especially characterized by emphysema, we always see presence of blebs, alveolar blebs, due to destruction of the alveolar walls, together with big air sacs, which has seen and even flattened lungs, flattened diaphragm, when the diaphragm is flattened. So these features can tell you that this person can have a problem of COPD, majorly seen in the third half of the lung. That is diaphragm flattening, increase in identification of the air sacs and the blebs, which can be easily seen. Then with the CBC, in the presence of asthma, we can see there is increased eosinophils on a CBC and sometimes increased lymphocytes. Then with COPD, we normally see there is neutrophilia, increased levels of neutrophils and sometimes monocytes. So this we can distinguish between asthma and COPD. Asthma is eosinophilia, whereas COPD there is neutrophilia and monocytosis. So these are the diagnostic measures we can always apply to diagnose COPD and asthma. Not forgetting the first expiratory volume to first vital capacity ratio, which we said that if we do this and we find this ratio is less than 7, it confirms COPD together with asthma. Then we did this test to confirm if it is either COPD or asthma by doing either provocation test, that is methacholine, or looking at the chest x-ray or the CT scan. Then if we can even use first expiratory volume in 1 second to first vital capacity ratio to characterize or to classify the severity of COPD. If you get the ratio, if the ratio is between 60 to 80%, this is mild COPD. We're using it to classify COPD. If you get the ratio between maybe 40 to 60%, this is moderate. Then between 30% to 40%, that is severe. Then less than 30%, that is very severe. This one becomes very severe COPD. After doing forced expiratory volume in 1 second versus forced vital capacity ratio, if it is reduced to this extent, this is what we are calling, we said the normal for confirming COPD it should be less than 80% or 70%. So above 80%, that is very normal. Then below, we use the figures to classify the severity of COPD. Hope you have gained a lot about what causes asthma and COPD, the signs and symptoms, the pathogenesis, that is how they come about, and the diagnosis. Thank you so much for learning with us. In the next video, we are going to look at the drugs which we use to treat asthma and COPD. So don't miss it. Thank you for listening. May God bless you.